Welcome now today for studying adenomyosis uterus. It is an important cause for abnormal uterine bleeding, and we place it, if you remember, FIGO classification of Palm-Coin, P for polyp, and we studied it in previous segment, A for adenomyosis. L for duomyoma of uterus, that will be dealt with in subsequent class. So first is adenomyosis. It means presence of ectopic endometrial glands inside the myometrium of the uterus. And it is simple to remember adeno means gland, myoma means muscles. That means the glands are embedded into the muscles of the uterus. It was discovered by a German pathologist, Karl Rogitansky, and he actually narrated the incidence to be from 5 to 70%, as it was till then considered only a histopathologic diagnosis. Now, the first question for this segment is, where else have you heard this name Rokitansky, and it is associated with ovarian tumor? That becomes the follow-up work. Actual definition has been recently given by Bird, which defines adenomyosis as benign invasion of endometrial glands into the myometrium, producing an enlarged uterus, which is diffuse, which on microscopy exhibits a benign ectopic endometrial glands and stroma presence surrounded by hyperplastic myometrium. And this hyperplasia around the ectopic glands and the stroma of the endometrium produces the diffuse enlargement of the uterus. Classical presentation, I've made it easy to remember. Just remember 3 Ds. One D is dysmenorrhea, and often this dysmenorrhea is severe and progressive in nature. So dysmenorrhea otherwise is a common association with menstrual cycle, but the dysmenorrhea and the pain which goes beyond 7 on visual analogous scale, you should think of adenomyosis. Second is dyspareunia, that to deep dyspareunia, when there is intercourse and the penile trauma and the thrust creates a dyspareunia, that is painful intercourse feeling, then this diagnosis of adenomyosis should be considered. And finally, dysfunctional uterine bleeding, which is usually heavy bleeding. Now we obviously don't call it as DUB, rather it has been replaced by the term abnormal uterine bleeding. But just to remember for 3 Ds, first D is dysmenorrhea, second is dyspareunia, and third is dysfunctional uterine bleeding, which is usually heavy and prolonged menstrual bleeding. Causes and risk factors. One, we have been reading it that it is a disease of multiparous females, usually aged more than 35 years. Wherever there are histories of repeated endometrial curettages, there it is thought that endometrium seeps into the myometrium prior uterine surgeries, especially myomectomy. When the patient is obese and smoking, the risk factors increase many folds. Antidepressant use, and in fact in some of their studies, patients having depression are also having more incidence of adenomyosis. Tamoxifen use and familial and genetic predisposition is also finding a new way into the causative etiology of adenomyosis. One very important finding is increased prolactin levels. Females who are having indigenously increased prolactin levels may be due to microadenoma and macroadenoma, and wherever it is induced by drug intake like domperidone, there also they are having more incidence of adenoma. So diagnosis is classically made by history, presence of 3 Ds, that is dyspareunia, dysmenorrhea, and dysfunctional uterine bleeding. Sometimes history may also give you inputs regarding presence of chronic pelvic pain. There is presence of subfertility. When you examine such a patient, a palpable, diffusely enlarged uterus, sometimes up to 14 to 16 weeks size corresponding to gravid uterus, and tender. So such an examination finding should prompt us to think of adenomyosis. When we do vaginal examination, again the uterus is diffusely enlarged. Now it is globular in feeling, and this differential enlargement of posterior wall of uterus causing retroversion due to heaviness in the posterior wall of uterus is almost pathognomonic of adenomyosis of the uterus. When we examine during vaginal examination, tenderness will be quite pronounced. And historically, I mean, when we were residents, we were taught to examine a patient of adenomyosis during menstruation, and it was thought that it will be extremely painful for the patient and it will lead us to making a prompt diagnosis of adenomyosis of the uterus. So tenderness during vaginal examination, more so if you have done it during a menstrual episode and it is very tender, then again it reveals that we are dealing with a case of adenomyosis. When you're examining such patient, fibroids of the uterus is quite frequently associated with adenomyosis. In fact, around 35 to 45% of the histopathological specimens show association of fibroids with adenomyosis. Now, endometriosis may also coexist in because all of these are estrogen dependent diseases, and these pathologies are basically coming up where excess of estrogen is there or prolonged exposure to estrogen is present. Differential diagnosis of a diffusely enlarged uterus are fibroid, pyometra, hematometra, leukometra, uterine sarcoma, endometrial carcinoma, and sometimes adnexal mass, especially which are appearing in front of the uterus, more so a dermoid cyst. Three forms of the adenomyosis have been distinguished, and these are very important to remember, and clinically also they may give you some insight. First is diffuse adenomyosis, where the glands and stromas present diffusely inside the myometrium. It is the commonest morphotype. Second is focal adenomyosis and adenomyoma, and it is a distinct variety of adenomyosis. Entire uterus is okay, and there is focal adenomyoma sitting. And most importantly, one thing that we have to remember is these are the cases where the primary diagnosis is that of fibroid uterus. The surgeon tries to enucleate that fibroid, and there is no plane. Surgeon is unable to dissect and find out very nice plane, which is a feature of fibroid uterus, and thus a final disease maybe at that time, or in histopathology we come to know that we were dealing with a case of focal adenomyosis. Third and last is cystic adenomyosis or adenomyotic cyst, which is a rare form. Here, basically the endometrial glands and stroma, the ratio of gland is more. That is why the cystic consistency and presence of fluidic substance is more. But yes, again, it is a rare variety. Most common, as I said, is diffuse one. So investigation, half of our diagnosis was made on clinical examination and history taking, but yes, we need ultrasound to improve the sensitivity, specificity, and to design the approach and treatment for our patient. It is a very good modality, and transabdominally, the sensitivity and specificity may vary, but transvaginally, it is reported to be as sensitive and specific as MRI. So sensitivity of a transvaginal ultrasound is around 89% and specificity is also 89%, which is same as that of an MRI. Finding that you will be finding in case when you do ultrasound for these patients, there is heterogeneous echogenicity and appearance of the myometrium. There is myohyperplasia. Ratio of anterior wall to posterior wall thickness is more than 1. We usually call this as Venetian blind or rain shower appearance owing to salt and peppery kind of consistency. It is also famously referred to as cirrhosis of the uterus owing to the presence of these features on ultrasound. We can also find myometrial cyst, which is cystic type of adenomyosis. There is loss of endomyometrial junction line and irregularity of endometrial junction. In ultrasound features, the radiologist usually divides it into three categories: adenomyosis and vascularity. So first is adeno. So they define it as ectopic endometrial glands, and there are subendometrial echogenic linear striations, and which may also form, which may also extend from the endometrium and into the inner myometrium. There are hyperechoic island, irregular endomyometrial junction, and tiny anechoic myometrial and subendometrial cyst, which is a very, very specific sign, and it reflects glands filled with fluid, and cystic striations are also seen. Meiosis means muscular hyperplasia along with or without hypertrophy. There is focal or diffuse myometrial bulkiness, which may be asymmetric, typically of the fundal region and posterior wall. Focal lesions have relatively indistinct borders compared to leiomyomas, and this is how we differentiate fibroid from adenomyoma. There is asymmetrical myometrial thickening, and thickening of transition zone can sometimes be visualized as a hypoechoic halo, and this is known as hypoechoic halo sign also. It is surrounding the endometrial layer, which is of usually more than or equal to 12 millimeter thickness, but this is a less specific feature. Now, third feature is vascularity, which is mapped on flow of color Doppler. It is generally increased, and there are increased number of tortuous vessels penetrating into the myometrium, and areas of increased vascularity reciprocate the distribution of lesions. Thus, ultrasonologically, adeno, that is gland feature, myoma, that is myometrial features, and vascularity features help us to make a definitive diagnosis of adenomyosis. MRI is rarely required, but yes, if at all we are doing an MRI for other reasons also, most easily recognizable feature is the thickening of junctional zone more than 12 millimeter, either diffusely or focally, and the normal junctional zone thickness is around 5 millimeter. On T1, there are foci of high intensity, indicating menstrual hemorrhage into the ectopic endometrial tissue. On T2, it is an ill-defined, ovoid or diffuse region of thickening, often with a small signal region representing small areas of cystic changes. Contrast enhanced MRI just for making a diagnosis of adenomyoma is rarely required. However, if it is done, as I said, for other reasons, it shows enhancement of the ectopic endometrial glands, which is very, very specific. So, when we are done with the ultrasound and MRI and history and examination, we are almost 98% sure that this is a case of adenomyosis. Previously, it was said that adenomyosis can only be diagnosed finally on a histopathological examination, but now ultrasound features, the definition of them, and addition of MRI has improved the sensitivity and the specificity of a diagnosis prior to going for a surgical treatment. So as far as treatment goes, we have to see patient's profile, what are the goals. Suppose if we are dealing with subfertility patient with adenomyosis, the treatment line will change. And if we are dealing with a young female whose symptoms are just painful menstruation, then maybe NSAIDs and tranexamic acid to reduce the heavy menstrual bleeding associated with it can suffice. Oral contraceptive pills can be prescribed to these patients, although the success rates are a bit low and rates of discontinuation are high in OCP's group. GnRH analogs, not for routine treatment, but we are giving it before one fertility treatment, second, before we are going for surgery treatment, then it gives good results. There is drastic volume reduction, reduction in blood loss and pain associated with adenomyosis. Danazol, not so preferable owing to its androgenic side effects. Dynogest has cost limitations, and the evidence is not that robust that goes in routine prescription of Dynogest for adenomyosis. Now, one boon for saving the uterus in case of adenomyosis is LNG-IU system. It is locally acting. The concentration of levonorgestrel inside the myometrium and around the vicinity of uterus is around 800 to 1000 times as that of a parenterally or orally given drug. It gives wonderful results as far as reduction in the volume of bleeding is concerned, volume of uterus is concerned, and pain scores are concerned. So LNG-IUS in fact has become the primary modality of treatment, and it should be offered if it is not taken care by NSAIDs and tranexamic acid, especially in perimenopausal age group where uh, things are not very good, like bleeding is heavy, it is leading to anemia, and patient is not willing for surgery. You are also not willing for surgery. You also want to preserve uterus, then LNG-IUS is the best option. Other um, other treatment options that warrant some, a consideration is endometrial ablation and resection. Although the success rates are not high, and pain is basically not too much resolving after ablation and resection, because the core pathology, that is endometrial glands sitting inside the myometrium, are still there. We are just taking out the endometrium, so maybe we are treating their heavy menstrual bleeding but not dysmenorrhea. Uterine artery ligation or uterine artery embolization has also shown good results, but it is a reserved treatment for select cases. Excisional procedure like adenomyoma excision and reduction of myometria. Now, this can be done, but the efficacy of such a treatment is low, and the success rate are only 40 to 50% only. There are three excisional techniques described for adenomyomectomy. One is classical technique where a longitudinal incision is given on the uterus, reduction of myometrium is done, adenomyomectomy is done, and it is closed. Second technique is Fujishita technique, which describes an H-shaped incision, and it has shown better results in pain scores. Like pain is less after Fujishita technique. Another one is Osada technique, which is quite famous, where excision of the adenomyoma is done and reconstruction of the uterus is done using triple flap technique. This has the lowest recurrence rate as far as surgical treatment of adenomyoma is concerned. MR guided focused ultrasound treatment is a newer method, and it has shown excellent results in the treatment of fibroids. But for adenomyoma, it is presumed that it will be showing good results. Some studies have been done also which have shown favorable outcome, but we need more research and more evidence. Hysterectomy, if the definitive treatment, if family is completed and she's not responding to conservative management, then yes, hysterectomy can be offered to such a patient. But yes, always try to preserve uterus first. We have so many wonderful treatment options nowadays to treat adenomyosis. So that's all. We'll come up with questions yet again in further sections. Thank you for watching.